Good morning, everybody. Great to see you this morning. Thank you for joining. As always, I'd like to just give it a moment to let people get into Grand Rounds. We are fully on Zoom today and this week and next week as well. We have a couple of really nice presentations this morning with two of our own faculty members for the DEI Awards presentations. Before we do that, we have some updates. I'll turn the first one over to Dr. Harrington.
Great. Thank you, Errol. To quote our internal medicine residency program director, Ron Watalas, he likes to say that the best part of being program director in medicine is getting to work with amazing chief residents every year. And I think Ron is exactly right. It's really my privilege to be able to introduce the chief residents for 2024 to 2025. They will be the so-called pre-chiefs coming in the next few weeks. Haley Gallitzer, Vishnu Na, Solomon Samani, and Celeste Whitting. Let me now tell you a little bit about each of them. If you want the details on each of them, you can go to the Department of Medicine news site and read about Meet the Chief Residents. First, let's talk about Haley. Haley received her BA in psychology from Columbia. She worked then 2 years as a clinical research coordinator at Mount Sinai before enrolling in medical school at NYU. Like all of our chief residents, she excelled in medical school, and we were thrilled when she matched here in 2021 to continue her training. Haley has really focused a lot on physician wellness, and particularly resident wellness. She serves as the chair of the Internal Medicine Wellness Committee. She's on the GME Wellness Committee, and she plans to pursue a career in hospital medicine with a focus on physician wellness. Next up is Vishnu. Vishnu earned his BA in molecular and cellular biology from UC Berkeley. He then went to medical school at UCLA. As I've said, all of our chief residents excelled in medical school. He then matched with us, and quickly it became apparent that his clinical skill and his passion for teaching were superb. He has won the peer-selected Washner Award for outstanding performance in internal medicine as a second-year resident, and he's been involved in teaching the medical students in the practice of medicine course since he arrived here as an intern. He intends to pursue a career also in academic hospital medicine with a focus on medical education, clinical reasoning, and quality improvement. Solomon Samani is next. Solomon earned his BS in chemical and biomedical engineering from the Georgia Institute of Technology, went to medical school at Mount Sinai, but interestingly, during medical school, took a 2-year leave of absence to co-found and lead product development for Monogram Orthopedics. That was very successful work, and over the course of his years working there, he is associated with 9 patents. He also began a prolific career as a researcher, and he has well over 30 manuscripts already from the time that he was working in medical school. He's distinguished himself as a clinician, a researcher, and has been said by Ron, his endless enthusiasm and curiosity. He is the current chair of the Resident Research Interest Group and is intent on pursuing a career in cardiology with a focus on electrophysiology. Next is Celeste Whitting. Celeste earned her BS in biochemistry and psychology from the University of Maryland, went to medical school at Northwestern, where she was recognized early on as a leader, serving as a senator, the vice president of the Student Center, and also became actively engaged in research at that time. We too were thrilled when she matched here, and she's earned a reputation, like all of our chiefs, for outstanding clinical care and for her teaching abilities. She has been awarded the prestigious Arnold P. Gold Foundation Humanism and Excellence in Teaching Award from the medical school, and she's continuing to work on her research in areas of health equity with Drs. Fatima Rodriguez and Alex Sandu. After her chief resident year, she intends to pursue additional training in cardiovascular medicine. So join us in welcoming and congratulating our outstanding class of chief residents for the 2024-2025 academic year. Errol, back to you.
Thank you, Dr. Harrington. That's wonderful. Congratulations to our upcoming chief residents in the future. Dr. Harmon, I'll turn over to you for more updates.
Thanks so much. So it is my pleasure to announce this year's University Faculty Women's Forum Award recipients. So the Faculty Women's Forum is actually a university-wide organization that supports and advances basically women's careers on campus. This is another year for us where we have multiple members of our community of our department who are award winners. First, Dr. Upi Singh. She is the winner of the Outstanding Mentor Award, our Division Chief for Infectious Disease. Big congratulations. Kathy Garzio, our Senior Vice Chair for Finance and Administration, who is the winner of the Carol Mueller Outstanding Service Award. And finally, Dr. Lisa Goldman Rosas is a faculty member in our Division of Primary Care and Population Health, as well as Health Policy and Epidemiology. And she is a winner of the Early Career Award. So see these folks, please send your congratulations to them. Thanks so much. Okay, the next slide. Oh, yes. And then next week's Grand Rounds will be virtual, but they'll come from our residency program and our residency program director. So Dr. Wendy Caceres, who is in our Division of Primary Care and Population Health, and one of our associate chairs for diversity and inclusion, as well as Christine Santiago, who is one of our current chief residents, will be presenting on the health equity advocacy and research program in our in our internal medicine residency program, and the work that has been done there over multiple years now. So please join us for that Grand Rounds next week. All right, back to you, Errol.
Thank you, Dr. Harmon. Yeah, please do join us next week. And again, special congratulations to our colleagues. Next, we'll turn over to Dr. Dunn, who will also be introduced. A couple of announcements also introducing our speakers today. Dr. Dunn.
Thanks, Dr. Olsdaga. Well, if you recall, we had an event planned back in February that was affected by the weekly atmospheric rivers that we had back then in the winter. We pivoted this event, which focuses on Black Joy, to be held closer to Juneteenth. To that end, we will be hosting Kumba, a West African dance troupe, to perform on the Dean's Lawn on June 9th from 1 to 2 p.m. There will be a reception with food and drinks, and it should be a wonderful performance. We encourage you all to come out for that, and I think we'll be clear from any rainy delays in mid-June. So please use the QR code to register, or the link will be put in the chat as well. Next slide, please. And right before that, we will be having an anti-racist community conversation with Dr. Cornell West. This is put on by Stanford Medicine. Again, that is going to be June 9th from 11 a.m. to 1 p.m. It is a hybrid event. Will be taking place at LKSC as well as on Zoom. And you can register using the QR code. Of course, Dr. West is a scholar, political activist, and author, most famous for Race Matters and Democracy Matters. And we encourage you all to join that conversation as well. Finally, it is my pleasure to announce today's speakers, whose projects are supported by the Chair Diversity Investigator Awards. The awards were established to support research that addresses health inequities, social determinants of health, cultural sensitivity, outcomes improvement, health system access and utilization for racial, ethnic, and sexual and gender minorities, among many other possibilities. So to begin, Dr. Tim Woldeyesus is a clinical assistant professor in the Department of Medicine, Division of Primary Care and Population Health. He obtained his medical degree at UCSF and continued his residency at UCSF in family and community medicine. He was selected as chief resident, where he further developed as a clinical educator and administrator prior to joining the faculty at Stanford. His academic interests include alternative models of care, clinical informatics, and digital health equity. He practices full spectrum family medicine, which includes care for the entire age spectrum. He's driven to provide evidence-based, high-quality, culturally sensitive care, which he does at Stanford's Express Clinic and at the Roots Clinic in Oakland, making a difference in the community. Today, he will update us on his project, Cutting Health Inequities, a barbershop-based hypertension care model. Dr. Robert Huang is an instructor in gastroenterology and hepatology who seeks to use both science and clinical practice to improve the prevention, diagnosis, and therapy of digestive malignancies. His clinical practice is focused on the use of advanced endoscopic imaging procedures to improve cancer detection and therapeutic endoscopic procedures to remove or destroy cancer and precancerous lesions. His research is aimed at improving digestive cancer outcomes and reducing cancer disparities through data science, cohort building, and biomarker development. His research is currently supported by an NIH Mentored Career Development Award. And today he will update us on his project, The Association Between Local Area Immigrant Fraction and Prevalence of Cardiovascular Diseases in the United States. Please welcome me in joining both Dr. Huang and Dr. Woldeyesus.
Great.
I guess I'll begin. So I wanted to thank first and foremost the department and my division for supporting the project and the work and the invitation to discuss these efforts at Grand Rounds today. Before I begin, I have no financial or conflicts of interest in this presented material. And for this presentation, I wanted to start by contextualizing the need for the cut hypertension program, go through some of the historical evidence of barbershop-based care, an overview of our program, our early milestones, and then end on future direction. Before introducing the cut hypertension program, I think it's important to understand why it's even needed. And I wanted to begin by framing racial disparities in hypertension outcomes, particularly as they pertain to the blood pressure control cascade. Based on pooled data from the National Health and Nutritional Examination Survey from 2013 to 2018, Black individuals had the highest prevalence of hypertension among all racial groups. And despite comparable awareness and treatment rates, they had a significant step off in hypertension control rates, which then translates into a much higher cardiovascular disease morbidity and mortality. And unfortunately, this isn't the story of just hypertension, but also could be said of obesity, diabetes, and so on. And I think it's important to pause and reflect on what underlies these differences. Missing from that depiction is the influential role of racism and discrimination on health outcomes and how it results in racial disparities. And this oppression through racism and discrimination is played out through the vehicle of the social determinants of health, whether it's access to healthy food options to implement the DASH diet or barriers to participating in care due to policies that dictate health coverage or provider availability that's culturally congruent. These factors in the environment are a strong opposing force in the individual implementation of guideline-directed therapeutic lifestyle changes and treatment. In the clinical setting, we often push against patients for individual behavior change rather than recognizing and addressing the forces that are against them. That tension is perceived by the Black community and has detrimental effects to the Black community's trust in the healthcare system, which justly puts them in the impossible situation to comfortably engage in care. In this published statewide survey from the California Healthcare Foundation, it really captures how many Black Californians avoided care due to concerns of not being treated fairly or with respect. And I wanted to highlight this because I think it's imperative that we listen to Black Californians and recognize the impact of racism in healthcare, but also their experience of healthcare, and also look to healing in community institutions and in partnership with community institutions, such as the Barbershop, to repair trust due to the historical abuses of the medical system. Community-based interventions within cultural institutions isn't novel or new. I mean, it's been seen in churches and barbershops in the past as ways of increasing trust, access, and engagement. It's not only because it's a convenient way of meeting people where they pass multiple times per month to get their haircut, but also has a strong history as community hubs for the Black community to embrace and uplift one another. Since the roots in historical abuses of slavery and Jim Crow, Black barbershops have always been sacred grounds for the Black community across the socioeconomic spectrum. Being a safe space for thought exchange, vulnerability, and expression of their own identity, they are just simply much more than a place where you just get a haircut. So it's not just a theoretical model or a volunteer effort. I really wanted to ground this model in a strong evidence base and start by looking at the pioneering work of Dr. Sanders in the late 70s and how it laid the groundwork for the healthy heart community prevention in the 90s on using the barbershop as a venue for health promotion and barbershop screenings. This led to Dr. Victor noticing that there was an absence in evaluation research for this and similar interventions. It led him to design the first study focused on barbershop-based health promotion and capturing its effect on engagement and care. Through enrollment of Black men that were long-term patrons with uncontrolled hypertension in Black-owned barbershops, they found that the intervention group that received health education and were incentivized for continual blood pressure screenings and engagement and care had a marginal increase at 10 months in blood pressure control rates in comparison to those that just received educational pamphlets. In the post hoc analysis in the BARBA-1 study, they found that a major barrier to more robust blood pressure reduction was failure to intensify the medications dubbed the physician inertia. They found that patrons that were without primary care physicians that were treated in specialty clinics by pharmacists had a much more pronounced and a much larger blood pressure reduction than those seen by their primary care doctors. This informed the landmark study, which linked health promotion in the barbershops with treatment by pharmacists that are specialized in treating cardiovascular disease. And they essentially reproduced this study, but at a much larger scale. Barbershops were assigned to a pharmacist-led intervention with barbers that encouraged meetings and encounters with specialty trained pharmacists for medication initiation and intensification in the barbershop space versus the control group in which they just simply reproduce what the BARBA-1 study did, with essentially providing and encouraging lifestyle modification and doctor appointments for follow-up. And what they found is in this study, it was highly effective at reversing physician inertia. At 6 months, despite similar baselines in blood pressure at the beginning of the intervention, there was a significant impact in both the systolic and diastolic blood pressures at 6 months. This effect persisted across education, across income, access to care, and other risk factors that you would think would affect the control rates. And as you can see, it also was pronounced in meeting the blood pressure goal at 6 months as well, compared to the intervention group, or compared to the control group. This effect was sustained at 12 months, demonstrating the potency of this equity-centered intervention in not only increasing control rates, we're really combating these inequities in the effects of racism outlined in the previous slides. What about the patient experience? This study also looked at patient activation and patient satisfaction and their engagement, and found that there was higher scores across the spectrum, and that patients actually, compared to the standard of care, were quite satisfied with receiving care within this barbershop space. So as you can see, the efficacy of deploying an equity-centered intervention in the barbershop space can be effective at combating the downstream effects of racism and the social determinants of health. By way of community partnership and centeredness, we can improve control rates and patient experience of care despite the opposing force that racism often serves. And in recognizing the current gaps in the paradigm of hypertensive treatment and grounded in this evidence base, we co-developed with key barbershop partners and community clinics a real-world implementation of this intervention. And so driven by the community, for the community, our mission was to strengthen the capacity of barbers and cosmetologists to be health coaches and key members of our care team, in hopes of repairing the trust of our patrons and our community partners in the healthcare system within a safe community space, all in hopes of cultivating health and well-being through the intrinsic power of community paired with health promotion and access to treatment. Situated within a community-based organization like Roots, our program is quite fortunate to have the wisdom and sponsorship of such like a trusted clinical entity in the Black community. Our team, modeled after the Victor study, consists of a faculty pharmacist, Crystal Zhao, who under my supervision as the community physician and medical director, we work closely with our program staff and barbers in providing navigation, coordination, and support of this collaborative care model. Starting in the fall of 2021, due to the setbacks of the pandemic, our team set out to reproduce the impact seen in the evidence base and addressing these downstream effects with our community barbershops in the Bay Area. And unfortunately, our founder, Dr. Kitty Taylor, wasn't able to get the program started due to the pandemic and its departure, but has been critical in really forming this adaptation and actually organizing this team. Just to provide a quick overview of our services, all of our barbershops offer free blood pressure monitoring using validated devices with automated blood pressure measurement protocols and best practices for multiple consecutive blood pressure readings to ensure accuracy. All of these screenings are then submitted and reviewed, and for folks that meet criteria for uncontrolled hypertension, our program staff then works to enroll participants and schedule a visit with the barber pharmacist dyad for a compensated haircut appointment. Our barbers provide health coaching services to our participants and have received health coaching certification through UCSF, and that essentially delivers an adapted and culturally tailored curriculum for the barbershop space that emphasizes client-centeredness, strength-based, and really a focus on collaborative communication with our participants. There's then a warm handoff to the pharmacist for barbershop-based reinforcement of health promotion, and if indicated, evidence-informed medication management and intensification and point-of-care laboratory monitoring, all within the barbershop space. Our program staff then encourages primary care engagement or re-engagement through enhanced care coordination and navigation. And are really committed to the relationship-based, trust-oriented understanding of the barriers and gaps that contribute to the engagement of our participants back into their care team outside of the barbershop space. We are in the infancy of the implementation of the program due to the impact and constraints of the pandemic. And even more so, our focus has really been cultivating a high quality participant experience that is community driven and led through an early investment of time for relationship building and trust building with not only our partners, but also clinical entities that we work with, all in hopes of having a more robust community impact. Thus far, we have 10 barbershop networks, 1 in San Francisco and 9 in Oakland. We've trained over 25 cosmetologists through our health coach training, and have formed an active barbershop advisory council to inform decisions within implementation, evaluation, and improvement of the program. Over the course of, since the start of fall 2021, we've had over 100 barbershop-based blood pressure screenings and 30 active participants, largely recruited from those community-based referrals and screenings in these barbershops. And thus far, have already had over 90 pharmacist, barber clinical encounters within the barbershop space. We have developed partnerships outside of Roots Community Health Center and recognize the importance of working with various primary care homes, from the safety net to privately insured. And more recently, we've been developing relationships with payers, of Medi-Cal payers, to be able to discuss early on the feasibility and sustainability of this model within the Bay Area. We recently just had one of our first patients to graduate from the program. And I wanted to highlight that this is an individual that previously was not engaged with primary care and was screened at one of the barbershops, one of our barbershops in East Oakland. And through the program, we developed a deeper understanding of his fear with initiation and maintaining treatment. And over multiple visits, we were able to change and try multiple regimens, and over the course of a year, able to actually bring him to blood pressure goal, and actually see that sustained effect even 6 months post. We've also seen more activation in his willingness and trust in the care, in the healthcare system, and he is now frequently engaged with his primary care, now being at Roots. I think it's important to highlight the gratitude and the impact of our barber partners in embracing their role as community health workers. And this is one of our lead barbers of the East Bay Network, really showing his appreciation to being able to be recognized as such a crucial part of our model. Despite being in the infancy of the implementation, I think we strongly believe in the togetherness of our team and its ability to disrupt racial disparities through being community-driven in all aspects of the program implementation to process improvement, and really maintaining our mission alignment, and having an emphasis on being relationship-oriented and not only showing up for the community, but with the community. Our current and future direction, we are in the midst of program evaluation and improvement efforts to really capture our impact on blood pressure control, among other metrics of improvement, including primary care engagement. We are expanding our barbershop network, our offering of health coach training, and our fostering of clinic level partnerships for increased referral throughput and enhanced care coordination. We're also been piloting virtual care offerings to be able to eliminate some of the barriers related to the pharmacist having to be in multiple locations at the same time, and also have active collaboration with payers to explore how we can actually sustainably fund this model, and reimburse and highlight the value that our community partners lend in addressing these disparities. I just wanted to extend deep gratitude to everyone involved, including our program staff, Melvin, Candace, and our lead barbers, Ken and Donald, for really being instrumental in adapting this program hyper-locally, and as well as our funding partners. And that is it. I think, are we doing questions at the end of the presentation tomorrow?
Yes, we'll wait for questions at the end, and we'll go ahead and have Dr. Huang. Thank you so much, Dr. Woldeyesus.
All right, so one of the joys of technology is dealing with hiccups that occur. So my computer chose a bad time to not have great Wi-Fi reception. So I think what I'm going to do is I'm going to project my PowerPoint on my computer and give audio over the phone. Dr. Dunn, can you just confirm, is the audio clear and can you see my slides?
We can hear you and we can see your slides.
Okay, good. So apologies for that. And please, Dr. Dunn, if at any point during this presentation, if my audio becomes unclear, can you please just interrupt me and let me know?
Absolutely, will do.
All right. Okay. Well, good morning, everybody. My name is Robert Huang. I'm an instructor in the Division of Gastroenterology. It's my great pleasure to speak to you this morning about the role of immigrants in enriching and enhancing community health and resilience. And Dr. Dunn, I just, sorry about this. Is there a way that, let me see if there's a way I can share my, my video as well here. Start video. Okay. All right. Can you see me now?
Unfortunately, we do not see you.
Okay, I see myself here. Is there a way you can invite me to share my video one more time?
We see you.
I see you. Yeah.
We see you.
Oh, we do see you. Okay. All right. Well, okay, good. So I'm good to go. So audio's good. You can see me and the PowerPoint is broadcast.
Everything's perfect.
Yes.
Okay. All right. Sorry about that, everybody. All right. So the role of immigrants in enriching and enhancing community health and resilience. So first, my disclosures and acknowledgements slide. I'm currently being supported by an NIH NCI K08 award. I have no specific conflicts of interest to report with regards to this research. So first, I'd like to give a big shout out and thanks to the leadership of the Department of Medicine for supporting this research, for supporting my career, and for supporting diversity, equity, and inclusion in general. Bob Harrington and Kathy Garzio have been real leaders in this regard. I'd like to thank Dr. Dunn, Dr. Caceres, and other members of the selection committee. Wonderful initiatives like this, like the Chair Diversity Award, to support young investigators in diversity science and equity and inclusive science, are a hallmark of our department. And I am so proud to be a member of this wonderful Department of Medicine. So thank you all. Thank you, the leadership, for this opportunity to present today at the Grand Rounds. So I'd like to introduce our investigator team, myself on the left, and then I'd also like to give a great shout out and thanks to my mentor, Dr. Latha Palaniappan, a professor of medicine, a world-leading health disparities researcher, a primary care physician, and chronic cardiovascular disease researcher, and the founder of the Stanford Center for Asian Health Research and Education, Stanford Care. You might be asking yourself, why is a gastroenterologist studying immigrant health? And it's in large part because of the influence of Latha. I have always had an interest and a passion for improving health and health outcomes of immigrants, and we really bonded over this shared interest. And she took me under her wing and taught me epidemiology and data science. And so I'm so glad that we had a chance to collaborate on this project. I'd also like to acknowledge Dr. Deepa Shokeen, our postdoctoral fellow, who has worked assiduously over the last year to get this project nearly completed, and she generated most of the data that will be presented in this presentation. So first, I'd like to begin with a personal story. America is a land of immigrants and descendants of immigrants, and I am no exception. My parents were born in Taiwan, the Republic of China, and they were presented a very unique opportunity in 1979 to travel and study in the United States, actually, and to become doctors and physicians. And so the picture on the left is my parents in Philadelphia in 1979. This was right after they got married, and they jumped on a jet and they landed in Philadelphia, first time in America, and they started their lives and their careers together here. And they've always been so grateful for this opportunity to come to the United States, to learn medicine in the United States, and to practice as doctors in the United States. After their training, they moved to a small town in rural Ohio, which is where I and my brothers were brought up. And for the next 35 years, they hung out their shingle, that you could still do that back then, and started a small mom and pop shop practice in this small town of Ohio, and cared for the local community for the next 35 years. My parents always told me that, you know, in this area of Ohio, many of the residents had never even spoken with a Chinese American before, but these people were willing to trust their lives into my parents' care. And this made such a great and deep impression on them. And so, you know, ever since, watching them care for their community, I've always been fascinated by the role of immigrants and the intersection of immigrants in their communities. At the same time, my parents did their very best to become what they thought American is. So we grew up, you know, with baseball and barbecues. And I've also always been fascinated by that role of acculturation of immigrants and how that impacts health. And that was a motivation for this study. So regardless of your stance along the political spectrum, you must agree that immigrants matter. immigrants matter politically, economically, socially, and culturally. In this figure, we see the fraction of the American population, which is foreign-born, as well as the number of immigrants in millions. The American foreign-born population reached a nadir around 1970, where it was about 5% of the population, and it has been increasing rapidly ever since. In 2021, we estimate there are about 46 million Americans who are foreign-born, which represent about 1 in 7 of the American population. By 2050, this number is expected to grow to about 65 million, or nearly 1 in 6 Americans. As impressive as the growth of the foreign-born population has been, the shift in the distribution of immigrant origins is equally notable. Up until 1985, actually, the majority of immigrants to the United States were white. From 1985 to the present day, the plurality of immigrants have been Hispanic in origin, and projecting into the future, we project that Asians will actually become the largest immigrant group as we move deeper into the century. So here I wanted to introduce the concept of the healthy immigrant effect. The healthy immigrant effect is the somewhat paradoxical observation that immigrants have lower social and economic characteristics compared to long-term residents. Yet at the same time, immigrants have lower prevalence of age-related diseases compared to non-immigrants. So this is an example taken from the CAN-HEART study published a couple of years ago in Circulation. And so in this national database study from Canada, what they did is they looked at the risk of 10-year risk of major cardiovascular event, which was defined as either a heart attack or a stroke. And they compared long-term residents with first-generation immigrants from across the world. So the long-term risk, the 10-year risk of cardiovascular event for long-term residents was about 8% for men, 3% for women. And for almost every immigrant group, regardless of origin, whether it be Western European, East Asian, African and Caribbean, or Latin American, the risk of major cardiovascular event was significantly lower compared to long-term residents. The one exception was South Asians, where actually for South Asian men, the risk was higher. So this emphasizes the importance of disaggregating immigrant origin when studying immigrant patterns of health. So beyond the healthy immigrant effect, another interesting question is, can immigrants potentially affect their communities in either positive or negative ways? So that is beyond the personal health advantages that immigrants enjoy. Is there some neighborhood effect that immigrants have? And there is an emerging body of evidence that this might be the case. So this is a national study linking tax records with mortality data published by Raj Chetty et al. A couple of years ago, where they were looking for factors associated with life expectancy within commuting areas. What they found is actually within the bottom income quartile, the strongest predictor of life expectancy of both immigrants and non-immigrants within the commuting area was actually local area immigrant fractions. That is the percentage of the population which was foreign-born. This effect was so strong, in fact, that it was on par with median home value and governmental expenditure per capita. So these couple of studies were really the inspiration for our current research project. And our central hypothesis here is that beyond personal advantages, could immigrants shape the health behaviors of their communities? For instance, while immigrants we know have a personal health advantage, healthy immigrant effect, could they have indirect externalities such as through mediating physical activity, food choices, smoking, either for positive or negative, onto their neighborhood? And could this effect be measured? So to answer our central hypothesis, we posed two specific aims. Specific aim one was, does immigrant fraction influence neighborhoods and the health behaviors of both immigrant and non-immigrant populations? And does this effect vary by immigrant origin? And in this study, we were powered to study the two largest immigrant subgroups, Asians and Hispanics. Specific aim two was, does immigrant fraction influence community prevalence of cardiovascular diseases, namely coronary heart disease and stroke, among both immigrants and non-immigrants? And what was unique about our study is that whereas previous studies had relied on larger geographical units, such as county, of which there are about 3,000 in the United States, or metropolitan commuting areas, no prior study had the ability to look at a very granular, small geographical units such as zip code. There are over 30,000 zip codes in the United States. And so due to a recently released data set, the CDC Places 2020 data set, we were able to, for the first time, to access health behavior and health outcome measures at a deep, granular geographic level. This is an overview of our study methodology. Our exposure variable was the local area immigrant fraction. So that is the percent of the population within each zip code, which was foreign born. And this was taken from the 2019 American Community Survey data set. We also performed subgroup analysis by immigrant origin, and we were powered to study the two largest subgroups, Asian and Hispanic immigrant fractions. Our outcomes, which were taken from the 2020 CDC Places dataset, were coronary heart disease and stroke prevalence. These were self-reported. And so the Places dataset is based on BRFIS data. BRFIS is a national phone survey, which is conducted annually and administered to approximately 400,000 households a year. Through this linkage and creation of this cohort, we had a very, very well phenotyped data set where we could look at a number of potential modifiers, mediators, and confounders of the relationship between the exposure and outcome variables. These included age, sex, income, and education. We had access to a number of health access measures such as health insurance, cholesterol screening, access to primary care. We also had access to rich risk factor data such as smoking, obesity, activity levels, etc. So this core plot demonstrates all of the zip codes in the United States, of which there are over 30,000, and it's color-coded with the depth of the heat of the color corresponding to the immigrant fraction. So as you might expect, there are certain regions of the country that are much more populated with immigrants compared to other regions of the country. Here in the Bay Area, I believe we're about 35% or so foreign born, as can be seen in the figure. And there are also large areas of the country, like where I grew up, where there are no immigrants. And so what I will say is we excluded any zip code where there was either insufficient data. We also excluded zip codes where the immigrant fraction was less than 1%. And the reason we did this was that on our exploratory analysis, these very, very low immigrant fraction zip codes just had very different characteristics from all the other zip codes, and we just didn't feel that we could draw any meaningful statistical inference from these low immigrant zip codes. So these were excluded. So our final analysis included about 20,000 zip codes, which represented about 80% of the US population. So for specific aim 1, our first goal was to analyze the association between immigrant fraction and health behaviors. And we also wanted to look at whether there are differences between Hispanic and Asian immigrant fraction and health behaviors. For the most part, both Hispanic and Asian immigrant fraction demonstrated similar correlational trends. For instance, with both increasing Hispanic and Asian immigrant fraction, we saw decreasing rates of smoking. But there were two important variables where this effect differed. The first was physical inactivity. So this was assessed by the question, during the past month, other than your regular job, did you participate in any physical activities or exercises such as running, golf, gardening, walking for exercise? And with increasing Hispanic immigrant fraction, we see that actually the prevalence of physical inactivity increases. The opposite is seen with increasing Asian immigrant fraction. Similarly, when we look at obesity, with increasing Hispanic immigrant fraction, the prevalence of obesity increases, whereas with increasing Asian immigrant fraction, the prevalence of obesity decreases. So this was our primary analysis. So this is where we added all the immigrants together, so Hispanics, Asians, whites, and blacks. And so we looked at all immigrants and we looked at the association between immigrants and coronary heart disease prevalence at the level of the zip code. what we did is we categorized zip codes into quartiles based on the immigrant fraction. So the first quartile is the lowest fraction of immigrants, and the fourth quartile is the highest fraction of immigrants. And then we calculated coefficients of association and then progressively adjusted for more and more variables. So model 1 represents our minimally adjusted model, which is just adjusted for age and sex. Model 2 has everything that model 1 is adjusted for, but adds on additional variables such as access to primary care physicians, access to cholesterol screening, etc. Model 3 is additionally adjusted for differences in smoking prevalence and activity levels and other behavioral variables. And then model 4 is adjusted in addition to that with obesity. And what we find is that in our fully adjusted model, the prevalence of coronary heart disease was about 0.5% lower in the highest quartile of immigrant fraction compared to the lowest quartile. So this is a small but significant effect, as the overall prevalence of coronary heart disease in our cohort was about 6.6%. This represents an 8% reduction in coronary heart disease prevalence between the highest and the lowest immigrant quartiles. We then did subgroup analysis by immigrant origin, looking at Hispanics in the table above and Asians in the table below. And we again sequentially adjusted for more and more potential confounders of this relationship. And what we found in our fully adjusted model is that both increasing Hispanic and increasing Asian immigrant fraction were associated with a decreased prevalence of coronary heart disease. In our fully adjusted model, an approximately 5 to 6% reduction in coronary heart disease prevalence is observed in the highest Asian and the highest Hispanic immigrant quartiles compared to the lowest Asian and the lowest Hispanic immigrant quartiles. This is the primary analysis for stroke. Again, this is the aggregating all immigrants together, in this case, categorizing into quartiles and calculating coefficients of association. The effect is more modest for stroke. So in the fully adjusted model, the prevalence of stroke was about 0.1% lower in the highest quartile compared to the lowest quartile of immigrant fraction. Given the overall prevalence of stroke in our cohort, this represents an approximate 3% reduction in stroke prevalence between the lowest and the highest immigrant quartiles. We then also performed subgroup analysis by immigrant origin, Hispanics in the table above and Asians in the table below. And what we again see is that in the fully adjusted model, Hispanic and both increasing Hispanic and increasing Asian immigrant fraction is associated with a small but significant decrease in stroke prevalence. This is particularly interesting because of the differences in the relationship with the potential confounders of obesity and physical inactivity that we were seeing above. Yet after adjusting for all of these values, increasing immigrant fraction for Hispanics and for Asians was associated with a reduced prevalence of both stroke and coronary heart disease. So what's going on here? We wanted to kind of deconvolute or decompose the direct and indirect effects of immigrant fraction on the outcome measures. In this case, I'm showing the figure for coronary heart disease. So we did structural equation modeling or path analysis. So in this figure, what we're seeing are both the direct relationships between immigrant fraction and coronary heart disease, the outcome, as well as indirect relationships mediated through intermediaries such as through smoking, through obesity, and through physical activity. So in our quartile-based analysis, what we found is that even after in our fully adjusted model, adjusting for all kind of potential confounders, we still found a significant relationship between immigrant fraction and coronary heart disease. And indeed, this is what the path analysis shows as well. The box here shows this direct relationship between immigrant fraction and coronary heart disease. To put a number, a figure of magnitude on this association, it's about for every 1% increase in immigrant fraction, there's a decrease in coronary heart disease prevalence of about 1.3% within that zip code. But beyond this direct effect, there also appears to be significant indirect effects. So for example, looking at the path on the far left of the figure, we can see that immigrant fraction is inversely associated with smoking, current smoking, and current smoking is a risk factor for coronary heart disease, as evidenced by the positive coefficient, which is highly statistically significant. So beyond this direct effect of immigrants on coronary heart disease, we see significant indirect effects mediated through differences in deleterious health behaviors such as smoking, physical inactivity, and obesity. We also performed path analysis based on immigrant origin, looking at Hispanic and Asian immigrant fractions. And what we again see, which is consistent with the quartile analysis we were performing before, is that there is a direct effect. There is a direct path between Asian immigrant fraction, Hispanic immigrant fraction, and coronary heart disease, such that a 1% increase in immigrant fraction is associated with about a 1 to 2% decrease in coronary heart disease prevalence within that zip code. When looking at indirect effects by immigrant origin, the picture is a little bit more nuanced. For Asian immigrant fraction, there do appear to be these indirect effects mediated through smoking, physical inactivity, and obesity. For Hispanics, because of this different relationship of Hispanic immigrant fraction on obesity and physical inactivity, the indirect paths are not as clear, but this is something that we're still doing some active analysis on right now. So the conclusions of the study are that there appear to be a modest, though significant, direct effect of local area immigrant fraction on coronary heart disease and stroke prevalence at the level of ZCTA. This direct effect persisted when analyzing the two largest subgroups of immigrants, namely Asians and Hispanics. And this is despite differences between these two groups. This may represent some common protective mechanism which immigrants provide their communities. There also exists significant indirect effects of local area immigrant fraction on local coronary heart disease and stroke prevalence, mostly mediated through differences in deleterious health behaviors such as smoking or inactivity. These effects do appear to differ by immigrant origin. We believe this is one of the first national studies to analyze local area immigrant fraction at the level of zip code. There have been some prior studies which have been based at larger geographical units such as county or commuting zone. Conversely, there have been studies that have focused on smaller geographical units, but they have been confined to or isolated to one geographical locale, for example, Los Angeles County or Chicago. So the results presented here provide generalizability to the entirety of the United States. We were able in this case to decompose both direct and indirect effects to see how immigrants and increasing immigrant fraction can impact health. And finally, we performed racial and ethnic disaggregation of immigrants with the interesting finding that despite this difference in the relationship between Hispanic and Asian immigrant fraction on obesity and physical activity, there was some, after adjustment for this, there was some common protective mechanism of increasing immigrant fraction on cardiovascular diseases. In terms of limitations, our outcome measures and potential confounders are based on self-report. This was a phone-based survey, which may not capture all households, especially immigrant households. The study was cross-sectional in nature, and whereas we use structural equation modeling and path analysis to decompose direct and indirect effects, we cannot make any statement on causal relationships based on the study design. And finally, we chose to exclude very low immigrant communities, those zip codes with fewer than 1% immigrant fraction. And as such, our results may not be generalizable to certain communities in the US, especially rural communities. And I think with that, I'm approximately at time. I'd like to thank you all for your good and kind attention this morning, and I'm going to return the presentation back to Drs. Dunn and Osdolgo.
Wonderful, Dr. Huang, thank you so much. And also Dr. Woldeyesus, thank you as well. By the way, perfect timing for both, so much information that was put out by both of you, and thank you for leaving time for questions. Dr. Woldeyesus, I saw you've been, and thank you for answering some of the questions that have been already coming up. I might jump to you first, and then Dr. Huang, I'll come back to you as questions are already coming up as well. For those of you asking questions for Dr. Huang, please do continue to do so. I'll try to combine a few. And also upvote ones that you like most. Dr. Woldeyesus, again, you noted you answered some questions. I want to do a quick shout out to Dr. Golden. He asked a question, when did barbershop clinics start and who started the research? I know some of that was covered, but that is a new record. That question came out at 8:01 a.m. So before the presentation started, that's the quickest question that we've ever gotten. So thank you, Dr. Golden, always for asking wonderful questions, by the way. So thank you for that. And, Dr. Woldeyesus, if you have anything to add to that, I just want to ask a couple more questions that you did answer here, but I want to make sure everybody saw these questions and your answers. Dr. Chu had asked, would it be feasible to have beauty salon clinics for women? You answered that, I'll let you answer, but also another great question about what an awesome project. Are you planning to expand to chronic diseases like diabetes, point of care, blood glucose, A1Cs, counseling? You also had a great answer there, but I'd like to get your answer live so make sure everybody hears it.
Yeah, so we actually early on by the influence of our health coach trainers and trainees, we really try to incorporate cosmetologists in our health coach trainings and in thinking about partnerships. And so we do have a couple beauty salons as sites for participants to pick to be able to have their appointments at. And I think we are, in terms of expanding to other chronic diseases, we are looking at optimizing the delivery model for hypertension, and we're currently looking at how we can incorporate and inform cardiovascular disease risk, and even explore starting statins within the barbershop setting as well, and then exploring how it could be applied to other use cases. And so that's definitely something that we're thinking about. I think the third question, so the pharmacist independent of medication initiation is involved in all appointments for individuals with uncontrolled hypertension, even if it just means reinforcing some of the lifestyle counseling and health coaching offered by the barbers. And oftentimes what we find is after a couple of visits with a trial of implementing these lifestyle modifications, we then open up the path to medication management. And so it does facilitate a little bit of a trust building and relationship building.
Oh, that's wonderful. I love all those questions and a lot of questions about the future of where this is going. We've been hearing about this work in different ways for so long. So thank you for sharing more details about it. This is really awesome. Just a call out, I'm going to switch over to Dr. Huang, but if there are other questions for you, Dr. Woldeyesus, if it's okay with you both, we're 3 minutes before 9, but it might go over a couple minutes if needed, if that's okay with you both. Great, thank you. Jumping over, Dr. Huang, a lot of questions here for you as well. We have a question here from Thomas Burns. How are you defining the immigrant fraction? Only first-generation immigrants? Is coronary artery disease and stroke benefit lost in second generation or higher immigrant fractions? I was wondering that as well. A little bit of, you move to America and then you get more of the cultural change, and how is that affecting further generations and so on?
Yeah, great question. So for the purposes of the study, we defined immigrants as only first generation. So if you were born in the United States, like I was, then you would not have been counted in the numerator for that study. But with regards to the second question of, are some of the protective effects of immigration on cardiovascular diseases lost in the second generation? The answer is yes. It seems that much of the protective, or at least some of the protective effect is lost into the second generation.
Great. A question here from Dr. Garcia states, great work and presentations, both Tim and Robert. Robert, it strikes me that zip codes have larger and more heterogeneous distributions in wealth and other measurements of socioeconomic status, and neighborhoods are much more homogeneous. Do you think that data at neighborhood level would show greater effect of immigrant fraction on coronary heart disease and effect?
Yeah, I think the more granular we could get with our data, the better. So zip code is probably better than county. So counties, you have Los Angeles, which is 10 million, and you have like where I grew up, which is say less than 100,000. So you have like 100-time difference. With zip codes, there's still some variability. I think zip codes are somewhere between 20 to 50,000 individuals living within a zip code. So, we could always do better. And so if access to even more granular data sets become available, then that would be something that we would love to study. There's also this trade-off though with privacy. So one of the reasons it took so long to create such a data set was just these concerns. Once you get really small geographical regions, it becomes a little bit easier to identify people. So there start to become some privacy concerns.
Got it. Interesting question here. Thank you for sharing your work, Dr. Huang. Was xenophobia, especially on the rise in recent years, assessed in your studies, or were immigrants happy to tend to preferably enroll? With any challenges with that?
So unfortunately, we were not able to assess xenophobia in this study. That wasn't. This was based on the Burfus telephone-based survey, and so they didn't have questions, as far as I'm aware, at least, that they didn't have questions with regards to xenophobia. There are other ways to potentially measure structural racism, data-based ways, for instance, that are based on correlations between various, urban density variables, or distance to fresh food. There are ways like to indirectly get at that question, but no, that question was not directly asked.
And I might just go, if it's okay, one more question here, Dr. Juarez-Reyes. Interesting data on immigrant fraction. As an FYI, there's also a mental health protective effect in recent immigrants that is reduced the longer immigrants are in the US. So wondering if you have data on time since migrations. It's kind of similar to the next generation, but more to the first gen.
Yeah, right. So that's a very interesting idea too. Like the longer you are in your, the longer the time since the immigration, some of these protective effects lost over time? I'll be honest, I don't actually know the answer to that question. If you immigrated at a younger age versus a later age, whether kind of the protective effects attenuate over your lifespan. So something I can look into, but I don't know the answer.
Both Drs. Woldeyesus and Dr. Huang, I want to say a special thank you to you both for this amazing work you do. And most importantly, I want to turn to Dr. Harrington for some closing remarks.
Well, thank you, Tim, and thank you, Robert. This is exactly what we hope to achieve when we decided to make funding available for these awards. You've both exceeded our expectations. Tim, I have to give you a special shout out because Ron Victor was an important part of the American Heart Association, and as you know, died far too early about 5 years ago. He was an extraordinary man who did extraordinary work, and it's a delight for me to be able to see investigators like you carrying that legacy on. So thank you for mentioning him as part of the Dallas Barbershop study. It's an important part of the legacy. And Robert, I love the fact that you're a gastroenterologist doing this work, and that you've crossed into other areas, and that you're excited about those areas, and you're bringing important new knowledge to all of us. So keep up the great work. I hope, and I know both of you have said, okay, this is just the start. And again, that's exactly what we wanted to see. So thank you both. Thank you for your leadership. Thank you for your scholarship. And thank you for the really hard work that you're doing in the Department of Medicine. So back to you, Errol, for next week.
Thank you again, everybody. Next week, we are back on Zoom again, so please join us. Again, Dr. Woldeyesus and Huang, thank you so much for the great work you do and for sharing it with us today. Everybody have a great rest of the day. Bye-bye.
Thank you. Bye-bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.